Dr. Burgel first, and particularly regarding your study that you're leading, the French Compassionate Program on rare mutations. What have been the main advances so far, and what future perspectives do you believe are most promising to broaden therapeutic options in a more inclusive way, especially in countries like ours in Brazil, where access depends on the public healthcare system?
Okay. Well, thank you for your question. Actually, there are multiple questions in this one.
Yes.
So let's start with what we've done in France with the so-called French Compassionate Program. So we had a problem 3 years ago because we had a label in Europe, and France is within Europe, so we dependent on the European label. The label in Europe was limited to people with at least one F508 variant, and in France this represents genetically 83% of people with CF, meaning that 17% were not eligible to treatment and they had no access to treatment. But we knew that some patients within this group would respond to Trikafta, and we knew that because in the US at that time there was this expanded approval based on FRA cells, so in vitro models, for which 177 variants were approved. So we discussed with the health authority and we organized this study in which we were able to give treatment to people with no F508 variant for 2 months. And within these 2 months, we had to demonstrate at the individual level that the treatment was effective or non-effective. And if it was judged effective, then the government would reimburse the treatment for this patient on the long term. So over the past 3 years, we treated 650 patients, and we found out that 350 had positive response, so they were responders, whereas the other patients were non-responders because they had variants that do not produce CFTR protein and they don't respond to CFTR modulators. So the good news about the program, we started with 17% of people with no access to modulators, and in the end we have 7% with no access to modulators. And it's not only a question of access, they are not non-responders. So for these people we need new therapeutic options. But what happened is that we came from 83% of people treated to 93%. So it's 10% more, and it's a great achievement for these people.
It's wonderful. Yeah.
And we were also part of our data have been used by the European Medicine Agency, and very recently the label was expanded in Europe. When I say very recently, if I'm correct, it's on April 7th, 2025, so just 3 weeks ago. And 3 weeks ago, the label was expanded to a label where everyone with cystic fibrosis could get access to treatment, or is eligible. Access is something else because it's about reimbursement also. But the label is about every person with CF 2 years and older, and the only restriction is if you have 2 class 1 variants that do not produce CFTR protein. So it's a major achievement. And within this label, there's also a list of more than 500 variants that are considered responsive.
Right. Thank you. And now, Dr. Margaret, could you share, please, the key highlights on the study on Trikafta use in children between 2 and 5 years old, and how these findings may help expand access and improve care for the pediatric population?
Thank you so much for that question. I think I got the easy question. Not many questions in one question. So our study evaluating the safety and efficacy of Trikafta in 2 to 5-year-olds was very helpful, I think, and I hope will support the registration for its use in the 2 to 5-year-olds in Brazil. First of all, in terms of safety, we found a very similar safety profile to that seen in older patients, and also to that seen in ivacaftor in 2 to 5-year-olds. So there were some individuals who had elevation of liver function tests, so that definitely needs to be monitored routinely. But I didn't review the paper right before now. I think there maybe was one patient who had to stop and restart, but overall the safety profile was very encouraging. There was one child who had some behavioral changes, but it was not clear that they were due to the drug itself, because they had had some behavioral differences before initiating Trikafta, so it was felt to be possibly related. Other than that, it seemed to be quite safe, and again a similar profile to the older patients. And then in terms of efficacy, we saw a very dramatic reduction in sweat chloride, greater than that in older patients, and that's been seen in ivacaftor as well. And then we also saw a clinically significant improvement in the lung clearance index, which I think is very helpful for thinking about long-term benefits in terms of lung function. We did not see a dramatic improvement in weight or height, because these patients were already doing very well from a nutritional standpoint, so that was maintained over time. There were a few patients who had some improvement in fecal elastase, but looking at the group as a whole, we did not see a significant improvement in fecal elastase, which is a little bit different from ivacaftor, and not exactly sure why that is. I think the key thing about initiation of Trikafta in the 2 to 5-year-olds is not so much in terms of short-term benefits, because these children tend to be outwardly facing very healthy already, but in terms of minimizing long-term disease progression. So really keeping an eye on helping them to be healthy until they're 40, 50, 60, 70, 80 years old. I think that's really the long-term difference is what we see.
Dr. Margaret, I'll try. Okay. We are wondering, what is your opinion about starting Trikafta for patients asymptomatic, no symptoms at all, and good lung function, normal lung function? What are you doing in your center? Do you start for everyone? Do you think a little bit? Are you seeing some resistance maybe this way from the parents?
Yeah,
if the child is okay, it's good, and what are your experience in this matter?
Thank you for that question. I think that if a patient has cystic fibrosis as opposed to CF SPID, because some CF SPID patients have eligible genotypes, but if a patient has cystic fibrosis, I think it's very, very important to start it, even if the patient is outwardly asymptomatic, because we know from studies like ARREST-CF and other studies that there's already structural lung disease that begins very early. And again, the goal is to have minimal or no disease progression over the long haul, over decades. And I think that it's quite clear the earlier you start it, the more likely that will be the case. So we talk to parents about that they're unlikely to see any short-term changes in outcomes, because outwardly their child is asymptomatic, but that over the long haul they should keep them healthy for decades and decades and decades, long after I retire, for example. And we have not had very much resistance. Families need time to go home and think about it and discuss it with their family members and feel very comfortable in starting. And we do review all the risks, the potential for adverse effects, as well as the potential benefits. So I think if it started when the child is 2 versus 2.5, probably not so different. We want them to feel really ready. But I think that we've encountered very little resistance. Of all my patients, I can think of one that was resistant for maybe a year and then started it, but they've all ended up starting it. So we have a very thorough discussion, and it can take, you know, a couple of visits to go through that whole discussion. But I think they understand that the idea is for long term.
Thank you very much.
Thank you. I would like to do another question and to discuss something. Just remembering what you, Dr. Burgel, shared with us 2 nights ago in your lecture about the French Compassionate Program, when you said that the participation of patients and families were crucial, essential to help talk to the Minister of Health in France to help incorporate these medications. So could you talk about that, please?
Sure. Well, we managed to organize this program for multiple reasons, but well, there was a clear need for a program because a large number of people didn't get access to CFTR modulators, they were not eligible. So we needed to get approval from the government, and we needed also to get support from all CF centers in France, and to get also support from the patients, because we were all grouped with the same objective, and the objective was to get treatment to the patients. So when we discussed with the government, we made some kind of alliance between the doctors and the French Patient Association. So we wrote a letter together to the Ministry of Health saying, well, there's a strong scientific rationale for getting a program like this. We have a good drug, which is Trikafta. We have a lot of experience with this drug because we have experience in F508 people, including those with advanced lung disease, and we need to save lives. And we know that the treatment is very effective and it works very rapidly, and we have multiple biomarkers. We can ask the patients how they feel, whether they produce sputum, whether they have cough, whether they have exacerbations. Then we can measure FEV1, we can measure sweat chloride, we have access to CT scans, imaging. So there are multiple ways in which we can assess the response to treatment, and the response can be assessed in a short period of time, 4 to 6 weeks. And this is how, in a way, we lobbied the government with the centers and with the patient association. And we were quite successful in that, because for the government, they knew that somehow the program is going to work, and for them it's a good news. Yes. Not only for us and for the patients, of course.
Of course. Thank you very much.